Hi Medicos, this is Dr. Natisha Arora. I am a consultant radiologist based from India and I have recently passed multiple examinations which include the NEET PG, the FRCR, the European Diploma in Radiology and my USMLE steps 1 and 2. Giving so many exams, I have realized that there are some topics which are common to all these examinations from radiology point of view and also some very important clinical vignettes which are tested in such topics. My last topic was sarcoidosis. I hope you enjoyed that video. My today's topic is Aspergillosis. So let's start with Aspergillosis as it is very commonly tested. Okay, so let's start with our first MCQs. I have tried to concise the entire concept of Aspergillosis and what they test in 10 MCQs. Okay, so let's start. The first MCQ is, a 50-year-old man presents with several episodes of mild hemoptysis over the past month. He has history of treated pulmonary tuberculosis 6 years ago. He is afebrile and the physical examination is unremarkable. A CT scan of the chest is shown. Okay, so they have given you a basic HRCT image. This is an image-based question. You can see that there is an irregular cavity over here and there is some solid mass present over here. Right, so this particular thing, when you see that there is obviously this black thing for the NEET PG aspirants, if you are seeing this, I hope that you have the basic fundamentals. I'll also take a class on the basic fundamentals if you like. But here you need to know that whatever black thing is seen, it is basically your air present in the lung parenchyma. So this is basically your classical, if you see the options, reverse halo sign, air-crescent sign, crazy paving pattern and tree in bud nodules. So even if you don't know anything about this particular question, you can just use your logic that if you know that air looks like this, it looks like a crescent of air. Okay, so this is called as your air-crescent sign. This is basically your option B is the answer over here. But before we jump into the sign, you need to understand the basics behind this particular question. They have given you a history that the patient has hemoptysis. Let's break down the key points. Another thing that the patient has history of treated pulmonary tuberculosis. So basically the cavitary lesion which they are showing over here, it's a chronic cavity. Bahut times there was one cavity present and now there is something which is deposited into this ball. This is nothing but an aspergilloma, or what we can say it is a fungal ball. Okay, if you see it in layman terms, this is also something which is called as fungal ball. Another thing that the patient is afebrile. Okay, so this is very classical history. Patient ko zyada kuch history nahi hoga. Okay, patient doesn't have any fever. Yes, if the mass is big, then they may present with hemoptysis. There might be some bronchial artery erosions and that will lead to hemoptysis now and then. But then overall the patient's general immune status, it is absolutely okay. There is no immunocompromised history. Patient does not have any fever. They are most of the times asymptomatic or they may have mild cough. Okay, so that is basic history when they will give you a history of aspergilloma. Okay, so before I break down what happens, you need to know that the most common species, okay, for any of the Aspergillus infections which they test is Aspergillus fumigatus. Okay, now when we talk about the aspergilloma, the immune status, if I talk about the immune status, there are basically 5 different classifications of aspergillosis. So first is when the patient's immune status is absolutely normal. Okay, normal, then in that particular case, patients, they usually have some history of chronic long-term cavities, maybe history of tuberculosis, sarcoidosis, a big pneumatocoel, a bulla is there or a cavity is there. Okay, any of this history they have given, immune status is normal. There is usually colonization by saprophytic aspergillus. Okay, so this particular will lead to a formation of an aspergilloma which we had seen in the previous case. And that is nothing but a fungal ball. This fungal ball, it is basically an accumulation, okay, or conglomeration of some fungal elements, some mucus plugs, and all this particular thing will form a ball, okay, because of the chronic colonization that has happened, okay, and the patient is absolutely asymptomatic in this particular scenario. So that is basic about aspergillomas. Another thing, I'll just list what are the classification and then we will cover in different MCQs. If the patient's immune status is hyperimmune, okay, we have talked that the immune system is absolutely normal. What happens when hyperimmune means the patient has some history of asthma or maybe some cystic fibrosis, okay, when the IgE levels are also elevated, that is basically a hyperimmune system. Us case mein we will deal with ABPA. Okay, another thing is patient having a less immunity. So one thing is less immunity mein, okay, one is very less immunity and one is less immunity. I'm talking about just slightly less immunity. Maybe patient is having some sort of diabetes mellitus, or patient is an alcoholic, or patient is a very old age, like say more than 80 years, or patient is having severe malnutrition. Okay, I'm not talking about very severely immunocompromised, say HIV, which we'll discuss over here. When the immunity is very less, say in the patients of HIV, okay, that will be dealing with something else. Here we'll talk about semi-invasive aspergillosis. Semi-invasive aspergillosis, whereas this is invasive aspergillosis. So when we talk about invasive, again there are 2 types. One is bronchial form and another is angio-invasive. Okay, So I'll discuss about all these things in detail in my subsequent slides, but this is just a basic classification: normal immunity, colonization by saprophytic aspergillus, and that will lead to an aspergilloma or a fungal ball. Another is hyperimmune status, which is basically your asthma or basically in cystic fibrosis. Long-term bronchiectasis will happen when we talk about this ABPA. Another is when the immunity is slightly less, and another thing is when your immunity is very, very less. That is semi-invasive and then the invasive aspergillosis. So this is a broad classification, and we are now first dealing with this particular point, that is a normal immunity status. Okay, so the history which we had seen in this particular patient was that the patient was afebrile, there is no immunocompromised status, there is a cavity, there is a ball, this is air-crescent sign. Remember that this air-crescent sign, it is also called as a monod sign. Basically, monod sign is a variant, I would say, of the air-crescent sign, because air-crescent sign is also seen in another pathologies. Okay, so this leads to my next important point over here, where else you will see the air-crescent sign. So you can see it in TB, you can see it with Rasmussen's aneurysm. Okay, so here the basic funda is same, something present over here, and air is present between this particular ball and the particular lesion and the cavitary wall. That is the basic funda behind air-crescent. So here or be conditions में you can see, one is basically your TB, Rasmussen's aneurysm, or it can be seen with lung carcinomas also. Okay, a cavitary lesion can be present with squamous cell carcinoma. So most commonly it can be seen with that. Another thing you can see it is with the hydatid disease. Okay, so there are many signs in hydatid which we will cover in my subsequent lecture series, but it is very classically it can be seen with hydatid disease also. Very important thing about air-crescent sign is it is also seen with angio-invasive aspergillosis. Okay, which we will cover in the subsequent slides. But so air-crescent sign is not just limited to this aspergilloma, but when I am talking about aspergilloma fungal ball, okay, classically specific term which we use is monod sign. Monod sign. Okay, so that they can test to you that monod sign is seen in which of the conditions. So it is classically seen with this aspergilloma. Another thing is that this aspergilloma, this fungal ball, it is mobile. Okay, so this particular thing is mobile. Okay, so what happens, why I am telling you about this particular thing, this is mobile. So when they test you for HRCT, they can test you that what particular imaging sequence you will do. So you will do, if you want to confirm whether it is not lung carcinoma, it is not Rasmussen's, it is not TB, there are many other forms in which you can differentiate them. But if you want to be sure shot, you need to say that you will do a prone imaging. Okay, because what happens when you will make the patient lie prone, this particular ball will also move, and that you can easily see by differentiating your supine and prone images. So this is very commonly tested. It is very important in all of these examinations, and this is the main key point to differentiate your aspergilloma from the another differentials. Okay, so this is again you can see an HRCT image, and you can see that there is some solid mass over here. There are some specks of calcification also within this particular ball, this hyperdensities you can see, and then there is an air-crescent. This is the lucency of the air which is seen around this particular solid mass. Okay, so this is basically your air-crescent sign. Okay, so let's now move towards the differentials. I have already said to you, Rasmussen's aneurysm ko, or what is the way you will differentiate? You have to do a CT angiogram. When you do a CT angiogram, you can easily see an aneurysm which is arising from a pulmonary artery branch. That is very commonly seen with Rasmussen's. And monod sign also we have told that it is very specifically a term that is being tested for aspergilloma or fungal ball, in which your ball is going to move. Okay, so let's list it again for you over here. Hydatid disease, lung carcinoma, I would say typically it is tested for squamous cell carcinoma. It can be seen with TB or Rasmussen's aneurysm. So all this particular point you need to know that there is a crescent of air which is lying. So this is the differential diagnosis. And another most important I would say which is tested and which we'll cover in our subsequent slides, that is angio-invasive aspergillosis. Okay. There is a very important clinical thing which is associated in angio-invasive aspergillosis with air-crescent sign. It is going to basically represent recovery in those patients when you are basically starting these patients on immunosuppressants. Okay, so let us just talk about Are you able to see this MCQ now? Okay. So let us now talk about our second MCQ. A 28-year-old woman with long-standing asthma presents with worsening cough and wheeze. CT chest, central bronchiectasis with mucus plugging, some mucus showing high attenuation, no lung mass or cavity. Laboratory shows total IgE markedly elevated and peripheral eosinophilia is also noted. So most likely diagnosis. So we have seen that particular chart. I have said whenever the immune system becomes hyper, we are going to talk about ABPA. What is ABPA? It stands for allergic bronchopulmonary aspergillosis. Okay, so we are talking about a very hyperimmune system over here. Here the patient is having a long-standing history of asthma. Long-standing history of asthma, you can see IgE elevated, you can see there is some peripheral eosinophilia. So 3 important key points telling you that the patient's immune system is hyper. Here I have given you the image description. The patient is having central bronchiectasis with mucus plugging, some mucus showing high attenuation, but important thing to remember is that they can also give you simply an image which goes like this. So you can see over here that this is a central bronchiectasis. Okay, and you can see there is some sort of bronchial wall thickening, there are some air fluid levels. Okay, you can see that there is this particular bronchi. If you see this on the axial sections, they are going to look like this round signet ring cell type of an appearance because of the bronchiectasis. But inside this particular bronchus also there are some levels. This is mainly because there is mucus plugging present over here. Okay, so this is basically classical case of ABPA. So the key point is asthma, central bronchiectasis, high attenuation mucus because of the fungal elements, because they have high amount of manganese and iron, that is going to give this high attenuation mucus that is hyperdense on the CT images. And another thing is that they have high IgE and eosinophil counts. Okay, so we are talking about the ABPA. Another thing is in allergic bronchopulmonary aspergillosis, the same variant of the question, the most common HRCT finding is whether it is random nodules, central bronchiectasis with mucus plugging, diffuse ground glass opacities or subpleural cyst. Okay, so we are talking over here again, I have told you it is central bronchiectasis with mucus plugging. So if you are interested to know what is interested in knowing the pathology of ABPA, again you need to know that the overall immune system is hyper. Patient is having either cystic fibrosis or asthma. Okay, what happens? There is long-term colonization of the aspergillus. Because of when the aspergillus are colonized in this particular bronchial mucosa, what happens is there is some sort of immune reaction happening. There will be increase in the IgE levels and there is also increase in the IgG levels. So what happens? There is colonization of bronchi by Aspergillus fumigatus. These are going to release some fungal elements into the airway. So that is going to lead to either type 1 or type 3 immune hypersensitivity reactions. So this is a question which is commonly tested. What reactions do you see? What type of hypersensitivity? You see both type 1 because of IgE and type 3 occurs because an IgG is formed against this fungal antigens, and this antigen and antibody complex is ultimately going to get deposit into your bronchial wall. So you see both the type of reactions. Type 1 will lead to your acute symptoms and type 3 will lead to your chronic symptoms. Okay, there will be chronic symptoms. Chronic symptoms means because of this complexes that are deposited into the bronchus, it is going to lead to long-term inflammation and ultimately there is damage occurring into these walls. Okay, so that is both the type of reactions. So there is basically a lot of inflammation happening. There is eosinophilic inflammation, there is bronchial wall edema. It is going to lead to thick mucus plugs, and mucus plugs along with this fungal hyphae, this is going to appear hyperdense. This is going to appear hyperdense on your plain CT. Okay. So that's going to appear hyperdense. Now what happens is because of this constant mucus plugging happening, there is segmental lobar collapse or consolidation on the imaging because your bronchus is going to be obstructed. That is going to lead to collapse and consolidation. Okay. So what happens? Patient ko hum log will either give the steroids or either you basically give a spontaneous recovery happens in this patient that will lead to clearance of the mucus plug. Once there is clearance, there is resolution of the old opacity. Okay. Once it will be resolved. But what happens? The fungal elements are already present. So this entire pathway is going to repeat itself and that will lead to recurrence again in a new bronchopulmonary segment. This is going to lead to a new radiological imaging finding which is fleeting pulmonary opacities. Okay, one particular place it gets cleared off, again there is a hypersensitivity immune reaction occurring at another place, another segmental bronchus and a new opacity. So patient will give you this history of either eosinophilia with hyper IgE and there are fleeting pulmonary opacities. Again this is commonly tested with fleeting pulmonary opacities. You are going to give a diagnosis again of the ABPA. Okay, so this is an important criteria for the diagnosis of ABPA. This is adapted by Rosenberg-Patterson criteria. Okay, so this is tested especially in your NEET PG and FRCR two-way type of examinations. You need to know the acronym. Here is RT-PICS. Okay, so A stands for asthma. We have already seen this. Rhonchographic fleeting fixed pulmonary opacities. Okay, test will be positive for A fumigatus positive. There is an immediate same reaction because of the type 1 hypersensitivity. E stands for eosinophilia in the blood. P is precipitating antibodies IgG in serum to A fumigatus. IgE in serum is elevated more than 1000 international units per ml. Central bronchiectasis, which we have already covered, and serum A fumigatus. The S stands for serum A fumigatus. This is serum. So we have talked about both. IgE is also elevated and the serum A fumigatus specific IgG plus IgE is also elevated more than 2 times the value of pooled serum samples from asthmatics with Aspergillus hypersensitivity. Okay, so that is basic criteria for the diagnosis of ABPA. The minor diagnostic criteria is either there is Aspergillus fumigatus, mycelia in the sputum, or there is expectoration of this brown sputum plugs because these are all hyphal and the fungal mucus plugs that are being expectorated. So that leads to this classical brownish plugs. And then there is an Arthus reaction which is basically a late skin reactivity to the Aspergillus antigen. Okay, so that is basic diagnostic criteria. Rosenberg-Patterson criteria, RT-PICS, that is the mnemonic. We go for asthma, we go for rhonchographic that is basically fleeting pulmonary opacities. The test for the A fumigatus is positive because of an immediate skin reaction. There is an eosinophilia in the blood. There is precipitating antibodies IgG in serum to A fumigatus. IgE is also elevated. There is central bronchiectasis and the serum A fumigatus specific IgE plus IgE more than 2 times the normal values. Okay, that is your major diagnostic criteria which you need to remember. Let's move towards our third MCQ. A 26-year-old woman with history of asthma presents with recurrent episodes of cough, wheeze and fever. Chest X-ray shows patchy pulmonary opacities in the upper lobes. Repeat imaging after 2 weeks revealed resolution of the previous opacities and appearance of new infiltrates in different zone. Laboratory testing again elevated serum IgE and peripheral eosinophilia. Which of the following is the most likely diagnosis? So again we have given a history of asthma, elevated IgE, peripheral eosinophilia and with multiple pulmonary opacities which are fleeting here and there. So this is basically, even if you now don't look at the options, you can tick mark that this is a case of ABPA, which is allergic bronchopulmonary aspergillosis. Okay, so that is basic thing about your ABPA. Moving towards our next question, this is basically a little big question, so we'll break it down for you. A 63-year-old man with poorly controlled type 2 diabetes presents with a 3-month history of productive cough, weight loss and low-grade fever. Okay, so here you have some particular history. See, the patient is having diabetes, symptoms are present, and there is no history of TB. Laboratory test shows mild leukocytosis and elevated ESR. So this indicates that there is some current infection that is going on. CT chest shows consolidation with adjacent cavitation. The cavity has irregular thick walls with surrounding pleural thickening. So there is an irregular cavity with surrounding pleural thickening. No intracavitary mobile mass is seen. So this is not a case of aspergilloma. There is adjacent segmental bronchiectasis and mild volume loss of the affected lobe. What is the most likely diagnosis? So here we are going to talk about diabetes mellitus. Means that the patient is having an immunocompromised status. It is not very severely immunocompromised in diabetes, but yes, there is some immunocompromise present. Another thing is that there is some cavitation, there is consolidation, there is long-standing this history, 3-month history of productive cough, weight loss and low-grade fever. Okay, so what we are basically talking over here, if you just see this particular image I show you, this was the patient. Okay, he is having some irregular cavities, there is large amount of consolidation also present, and there is also associated pleural thickening which I have not covered in this image. So when they show you this keyword of pleural thickening, okay, and with this immunocompromised status, and they have clearly ruled out that there is no history of tuberculosis, okay, then the most important, see, it is not simple aspergilloma, okay, that because there is no fungal ball, then the patient is also having some symptoms, the patient immunity is also down and patient is having symptoms, so it is not simple aspergilloma. But if I talk about invasive pulmonary aspergillosis, can you say that it is invasive? We will better able to rule out this option when we will talk about invasive pulmonary aspergillosis. It is very, very aggressive, okay, the patient will present very acutely when we talk about invasive. इसमें acute symptoms होंगे. Whereas if you are being given a history of an immunocompromised status with symptoms and a subacute history, okay, that is a case of semi-invasive aspergillosis, which is also chronic necrotizing aspergillosis. Why it is not post-pulmonary or reactivation TB? Patient has no history of TB. So this is also you rule out. So your most best answer over here is semi-invasive or chronic necrotizing aspergillosis. Okay, so if you see the key radiological findings, semi-invasive aspergillosis occur in patients with mild immunosuppressions or either a chronic lung disease, which is diabetes or COPD. CT findings will show that there is some segmental consolidation, cavitation and irregular thick walls. There is surrounding pleural thickening and sometimes there is adjacent bronchiectasis. And another important key point is that there is some active local tissue destruction, which is either in the form of cavitation or very massive consolidation. So this is a case of semi-invasive aspergillosis, which is also called as chronic necrotizing aspergillosis. Okay, there is some local tissue destruction happening because of the immunocompromised status. So that is about semi-invasive. Key word over here is also remember that there is adjacent pleural thickening, which also gives you an history that something subacute. Pleural thickening will not happen something acutely. Okay, so pleural thickening is not going to happen acutely. It will happen chronically, subacutely. They will give you a history that 3 months a patient is having some history along with some immunocompromised status. So that is about your semi-invasive necrotizing aspergillosis. Okay, so now let's move towards our fifth MCQ. Which imaging finding is more suggestive of angio-invasive aspergillosis in an immunocompromised patient? Okay, whether it is tree in bud opacities, halo sign on CT, which is basically a ground glass around a nodule, or it is bronchiectasis with mucus plugging, or it is subpleural plebs. Okay, so when we talk about angio-invasive, patient immunity is very low. It's either a chronic case of HIV, or patient is having leukemia or lymphoma, or the patient is having long-term chemotherapy or radiotherapy, the entire immunity is very, very bad in this patient. Because of the colonization of Aspergillus, what happens is that they are going to now invade into your vessels. They go into your medium and small size vessels, and that is leading to not only this vascular destruction, they will lead to this vasculitis, there will be some tissue destruction, and there is a massive vascular spread happening over here that is going to lead to hemorrhagic necrosis. There is hemorrhages happening because your vessels are now involved. Okay, so that is basically the pathology in the angio-invasive aspergillosis. There is hemorrhagic infarction because of the involvement of the vessels. Okay, so whenever there is a hemorrhagic infarction, what is going to happen? There will be, see, if there is this consolidation present or there is a cavitation present, there is hemorrhage, that is going to lead to a halo sign in the form of ground glass opacity. Okay, so this is again very characteristically seen with angio-invasive aspergillosis, and you will see a halo sign on CT. See, tree-in-bud opacities is something which is commonly tested for your tuberculosis, okay, or something which is going to indicate an endobronchial spread. Okay, so endobronchial spread can also occur in invasive aspergillosis when we talk about the term broncho-invasive aspergillosis. But here the clinical term, clinically they have basically given a very but here basically testing you for angio-invasive aspergillosis. Okay, so whenever the vessels wala component is there, they are talking about halo sign only. Bronchiectasis with mucus plugging, this is seen with ABPA, and the subpleural blebs is nothing to do with this, right? So if you see this particular sign, you can see there are multiple nodules, and you can see that there is this halo present over here. Okay, so this is your characteristically halo sign. Okay, now another thing is that if you see, that basically discuss about the differentials of halo sign, because it is not classically just limited to angio-invasive aspergillosis. It is also seen with CMV and Candida infections. So both the C you remember, one is virus and one is a fungus. Another is it can be also seen with HSV pneumonitis. Okay, or kahan pe hoga? Wherever there are hemorrhages. So it can be also seen with lung contusions. Okay, and it is also very commonly seen with hemorrhagic metastasis. Now, where classically you see hemorrhagic metastasis, mets have multiple nodules with ground glass surrounding it. It is very classically seen with RCC, highly vascular tumors. Okay, so it can be seen with them. Okay, another thing is that air-crescent sign, I told you that air-crescent sign can also be seen with this angio-invasive type of aspergillosis. This occurs, what happens is that there is basically a solid nodule, okay, of this particular angio-invasive aspergillosis. Now, once you start giving them the treatment, you start giving them voriconazole or you give them amphotericin. Okay, what happens is that this particular fungal element, it is going to now sequester. It is going to sequester from the rest of the cavity. And what happens? There is a resultant air that is going to present between the cavity wall and between this sequestered fungal ball element. So that is going to be present, and this will lead to an air-crescent sign, which is classically seen 2 to 3 weeks after the treatment. So if they give you a history and an image with an air-crescent sign, they say that the patient is having angio-invasive aspergillosis and the patient has recently started taking antifungals. So this is basically indicating that this is actually improving. This is actually a sign of recovery happening. Okay, in the patients of angio-invasive aspergillosis. So whenever there is a recovery happening with the air-crescent sign we are talking about, so this is an important clinical vignette that recovery happens when the air-crescent sign is seen in the cases of angio-invasive aspergillosis. Okay, now another thing is that we do not, one thing I need to cover over here is when we talk about invasive aspergillosis, it's not just limited to angio-invasive aspergillosis. This can also occur in form of broncho-invasive aspergillosis. So instead of the vessels getting involved, your small and your medium-sized vessels getting involved by the aspergillus, instead what happens, there is widespread spread of the aspergillus in immunocompromised patients into the bronchial tree. Multiple mucus plugs can also form. Because of this multiple mucus plugging in the small segmental and subsegmental bronchus, this will lead to an appearance. You can see multiple nodules over here. So this is going to lead to an appearance of an endobronchial spread of aspergillosis. Okay, this can also be seen in tuberculosis. Again, the clinical vignette becomes very, very important. They will usually give you a history that the patient has no history of tuberculosis, or the tuberculin test was negative, or interferon gamma was negative, or the sputum is negative for tuberculosis. They will give you this history. If this history has been completely ruled out and they are giving you a history that the patient is having leukemia and lymphoma, or the patient is taking radio or chemotherapy, in that particular condition, start thinking about broncho-invasive aspergillosis if a tree-in-bud pattern of appearance on the HRCT image is given. Okay, so that is about broncho-invasive. So, and of course, this presents very acutely. Okay, this is going to present very, very acutely. Tuberculosis maybe itna acute presentation is very rare. This broncho-invasive aspergillosis is something which will present very acutely when once there will be an infection by the aspergillus organisms. Okay, next we are going to move in towards our 6th MCQ. In invasive pulmonary aspergillosis, the halo sign corresponds histologically to. So this is just a quick revision. We have already covered whether it is A, pleural reaction, B, hemorrhagic infarction, C, mucus plugging, or whether it is D, atelectasis. So of course it is hemorrhagic infarction around a fungal focus. Okay, so the answer over here is hemorrhagic infarction around a fungal focus. The halo will represent a hemorrhage surrounding an infarcted nodule. Okay, pleural reaction jo hai, it is either seen in TB or it is seen in semi-invasive or chronic necrotizing aspergillosis. Okay, because chronically this process happens, but when something acutely happens, we have to start thinking about angio-invasive infections with hemorrhagic infarction. Okay, C is mucus plugging of bronchioles. So it can occur with mucus plugging also, but when we talk about mucus plugging of bronchioles, they are more characteristically testing you for ABPA. And atelectasis and multiple fleeting opacities, again we are testing you for ABPA in that particular scenario. Okay, but halo sign is very characteristic and they test you for this. Okay, next is halo sign is seen in all of the following except, again we have discussed about the differential diagnosis. So whether it is A, vaginous granulomatosis, B, invasive pulmonary aspergillosis, C, sarcoidosis, or D, it is Kaposi sarcoma. So I have covered the very important differentials of halo sign over here, whether it is in the form of infections, which is CMV, or candida, that is CNC, you can remember. Another is HSV, then lung contusions because hemorrhage happening, and hemorrhagic metastasis. But then there are other conditions also where halo sign is present. So one important thing is that vaginous granulomatosis. Okay, this vasculitis, again vasculitis may be hemorrhage hota, and this can be vaginous granulomatosis. So of course this is not the answer. You will see halo sign over here. Invasive pulmonary aspergillosis, yes, we see it in the invasive pulmonary aspergillosis also. Sarcoidosis, no. In Kaposi sarcoma, again, there is a similar pathology. There will be hemorrhagic infarction happening in immunocompromised status in HIV. So you see halo sign in this also. So apart from all these particular things where you see halo sign, you also see them in Kaposi sarcoma and, so you also see halo sign in the Kaposi sarcoma. And you also see it in vaginous granulomatosis. Which antibodies do you see in vaginous granulomatosis? So just a quick jumping, it is seen with C and K antibodies. They are commonly seen, they are elevated in the vaginous granulomatosis. So here all these conditions you need to remember where the halo sign can be seen. So I am sure that now you understand how the halo sign looks. It is like a consolidation and there is a surrounding ground glass or a nodule with surrounding ground glass. Another thing is that there is something which is called as your reverse halo sign also. So what is this reverse halo sign? Here you will see that there is central ground glassing surrounding by a consolidation. So that is reverse halo sign. This is also called as your atoll sign. Okay, this is very characteristically seen with atypical pneumonitis. Okay, example, just say COVID may you used to see this reverse halo sign, but very classically this is tested for cryptogenic organizing pneumonias. We'll discuss it in more detail when we talk about interstitial lung diseases. Okay, but remember that this is very characteristically the reverse halo sign. Okay, exactly opposite to what you are seeing. Just the photographic negative of this, I would say that will be atypical infections or it will be cryptogenic organizing pneumonias. Okay, whereas halo sign ke differentials which we have already covered in detail: CMV, candida, HSV, contusions, hemorrhagic metastasis, Kaposi sarcomas, and vaginous granulomatosis. Okay, so if you will basically revise this becomes on your tip of the tongue. So it's very important that you keep on revising this stuff. Otherwise, differentials become little tough to remember. Again, next question, which sign is classically seen during the recovery from angio-invasive aspergillosis? Again, I have covered this in quite detail. So it's whether it is reverse halo sign, B it's target sign, C air-crescent sign, or D it is the head cheese sign. So here we are talking about is your air-crescent sign. Okay, so if there is a recovery happening during angio-invasive aspergillosis, we are classically talking about your air-crescent sign. Okay. Now, radiology wala point we have covered about aspergillosis. So a quick question on your microbio as well as pharmac I have covered in your 9th and 10th in a little USMLE style of question. So 9th is a 54-year-old man presents with history of COPD, presents with fever, cough and hemoptysis. Chest CT reveals a cavitary lesion in the upper lobe with a soft tissue mass inside, suggestive of a fungal ball. So when such big questions occur, what happens is by the time you reach to the end, you basically forget that what was the question all about. So my advice to you is either you highlight, okay, you usually get the options of highlighting in your exams. So patient is a 54-year-old man, okay, or you just underline, which is most relevant history. So patient ko here, the patient is having COPD. So COPD history is there. Chest CT reveals a cavitary lesion in the upper lobe with a soft tissue mass which is suggestive of fungal ball. Okay, so patient is having a fungal ball. Okay, some acute presentation is there. There is hemoptysis, there is some fever and some cough. A biopsy is performed on histopathological examination with methenamine silver stain. Again, very important point. Methenamine silver stain is used basically to test for this fungal elements of Aspergillus. So there are some slender hyphae with septations and branching are seen. The branching is dichomatous and occurs at approximately 45 degrees. Which of the following best describe these findings? Okay, so here you need to discuss that with the long-standing history of COPD, there must be some sort of emphysema or emphysematous bulla is present, or patient is also having some cavitary lesion. So we don't know, we are not given the history whether what type of cavitary lesion, and we don't have to diagnose that. It can be a cancer, it can be tuberculosis, it can be an emphysematous bulla, it can be a pneumatocyst, we don't know that, or it can be an abscess. But there is some soft tissue ball, and here we need to know that this soft tissue ball, immediately you start thinking about an aspergilloma whenever there is a ball which is being given to you in the question. Okay, now here they have already given you the diagnosis also that it's a fungal ball. So they are talking about an aspergilloma. So aspergilloma may classically, this is something which you just need to remember, you just need to mug it up. There is no there is no logic behind this question. So what type of hyphae are basically seen in the aspergilloma? Okay, so or the aspergillus is what type of hyphae? Moving towards our next question. So we have covered enough of the radiology. What I feel important in aspergillosis is a little bit of microbio and pharmac. So I have basically included two important questions, a little USMLE style quick clinical weakness which you need to know. So let's move towards this 9th question. Okay, so basically this can be tested in either of these forms. So just don't look at the options right now. Just look at the question. A 54-year-old man presents with history of COPD, presents with fever, cough and hemoptysis. Chest CT reveals a cavitary lesion in the upper lobe with a soft tissue mass inside, suggestive of a fungal ball. So we know that the patient is having a history of COPD. There is some cavity which is present, and it is basically they have told that it's a fungal ball which is present, right? A biopsy is performed. So we do a methenamine silver stain, which is commonly used and can be asked also what stain you use methenamine silver staining for staining these fungal elements and fungal organisms. So here there are some slender hyphae with septations and branching are seen. Okay, so if you see, they can give you this image. Okay, so if you see this particular image, you can see that there are some hyphal elements which are septated. Okay, which are septated. You can see the small septations are present, and the branching is 45 degree. It is not 90 degrees. It is 45 degree. So if they are basically testing you with 45 degree septate branching, septate hyphae and 45 degree branching, what they are basically testing you is for Aspergillus organisms. Okay, so this is very classically tested, 45-degree branching and septate. This is Aspergillus, whereas its counterpart, which is Rhizophis or Mucormycosis, they will have a 90-degree branching and they are usually aseptate. Okay, so this is commonly tested, so that is why I have included. Okay, they can give you the clinical, they can give you the options as acute angle septate branching hyphae, or whether it is perpendicular aseptate. So they will just mix those words. Okay, but you have to be very, very particular that when we talk about Aspergillus, it is acute angle and septate branching hyphae. Either they will give you this image with a clinical vignette, or either they will give you these particular options and they will just tell you that what organism is basically present. Okay, if they may also not give you the organism, they will just give you some history, and with this you just make the diagnosis of aspergillosis, and you need to break down your options whether it is Aspergillus or Rhizophis. Okay, so here in this case it is acute angle septate branching hyphae. Okay, another thing is that when we talk about a 55-year-old man, a 10th question, a 55-year-old man with acute myeloid leukemia develops fever, cough and hemoptysis while receiving chemotherapy. Chest CT shows a nodule with surrounding ground glass opacity. Again, we have talked about angioinvasive and halo sign very deeply, and the patient is having AML also, and all this will set into the angioinvasive wala category. Bronchoalveolar lavage culture, grows Aspergillus fumigatus. He started on antifungal agent. 2 days later, he reports blurred vision with seeing flashes of light. Which of the following drugs is most likely responsible for the symptoms? So here they are basically testing you that what is the most common side effect of the antifungal agent which they have given. So first you need to remember that when we talk about angioinvasive, the drug of choice is voriconazole. Okay, only when it is very, very resistant we start giving IV amphotericin, but before that you need to remember that the drug of choice is voriconazole, and a very common side effect of voriconazole is blurred vision. Okay, you will have this severe toxicity on the retina, and that will lead to this blurred vision and seeing the flashes of the light. So the answer over here is voriconazole. Okay. So when we talk about the mechanism of action, it is basically a triazole antifungal. It inhibits the fungal CYP450 enzyme 14-alpha demethylase, and this is going to inhibit your ergosterol synthesis. Okay, so this is the first line drug for invasive aspergillosis. The side effect is visual disturbances, photopsia and color changes. It can also lead to some sort of hallucinations, photosensitivity and hepatotoxicity. Okay, but the commonly tested thing is visual disturbances for voriconazole. Remember V for V, and it is basically for visual disturbances for voriconazole. Okay, so if you just see and look at this particular table, I am just going to concise everything for you over here. So if I talk about an aspergilloma, the typical patient, so I'm just going to, so this is our last slide, and we are just going to basically concise the entire aspergillosis into this entire table. So aspergilloma, the typical patient will be, okay, so first I'll just tell you the immune status. So here the immune status is normal. Here it is elevated, here it is decreased, whereas in invasive it is very, very decreased immune status. Typical patient will be usually asymptomatic. Okay, sometimes they may present with hemoptysis. If there is a very, very big fungal ball that is eroding into these vessels, whereas ABPA, the patient will be having either on and off symptoms will be present, but they will give you a clinical vignette over here of what clinical vignette they will give you, that the patient is having some sort of cystic fibrosis, asthma, long-term COPD, something like that. Whereas semi-invasive, I've already discussed about, either they will give you history of diabetes mellitus, or they will give you an alcohol history, or there will be some sort of malnutrition happening. Okay, so this will be like little bit less immunity. The another thing is that when we talk about invasive, it will be either they give you HIV or AML or lymphoma or any particular cancer for that matter, or chemotherapy, or they will give you a history of radiation or something like that. Okay, the onset and the symptoms, here there are no particular symptoms. Sometimes hemoptysis will be present, so there is no per se onset to talk about. Whereas if I talk about invasive, it is something which is acute. Semi-invasive will be subacute. It will be presenting for say around 2 to 3 months ka history they will give you. Whereas ABPA, okay, when they present with central bronchiectasis, again it can be either, depending upon the clinical vignette, it can be acute or it can be also chronic. Acute is mainly IgE mediated, whereas chronic is IgG mediated. Okay, whenever there is something which is acute, maybe an acute consolidation is present, chronically agar hoga, so what happens, there will be some sort of central bronchiectasis and mucus plugging. This central plugging and mucus plugging, this is also something very commonly tested, and which I forgot to mention in the ABPA. They will give you this central bronchiectasis. Okay, if you give this chest x-ray, this classical sign, this is also called as finger in glove appearance. Okay, so they will give you an x-ray and they will give you a finger in glove type of an x-ray. This is also called as a toothpaste sign. Okay, why toothpaste? Because it looks like that of basically a tube, and that has been completely filled with this mucus plugging. Okay, so this is about the key CT findings. You will see the monod sign over here, an air-crescent sign will be present. Okay, there will be a fungal ball we do for the prone imaging, is very important. ABPMA, they will have this central bronchiectasis. When we talk about central bronchiectasis, remember this is either finger in glove or either the toothpaste sign. If you see an axial section, which we have already shown, that will look like a signet ring level, and they will also have this air fluid levels within, or some bronchial wall thickening will be present. Okay, when we talk about the chest x-ray, they can also show you some fleeting opacities ka history, opacities here and there. Okay, एक जगह पे रिजॉल्व होती है, दूसरी जगह पे अपीयर होती है. That is again the complete link to that is the pathology behind the ABPA, which is either it is type 1 or it is type 3. But suppose it resolves at one particular place, maybe it is a self-resolution, or maybe you are giving some sort of corticosteroids in that particular patient, a new place, a new bronchial plugging can occur and a new opacity will appear. Okay, whereas semi-invasive you will see that it is locally invasive, so that will lead to some irregular cavity, or there will be some sort of consolidation happening, but there is an associated pleural thickening present because there is some local tissue destruction and chronic process that is happening, so that will be some pleural thickening with cavity and consolidation will be present. Whereas if I talk about invasive, very our favorite halo sign can be seen in that particular patient. That is commonly tested. Tree-in-bud opacities and all those can also be present, but that is not commonly tested. They test you only for angio-invasive or the halo sign. Remember the various differentials of halo sign, that is very important. Whereas management के बारे में बात करें, aspergilloma you per se don't have to do much, but if the patient is having hemoptysis, you might have to go, either you do nothing, but if the patient is presenting with hemoptysis, you have to go for a bronchial artery embolization in that case, or surgery if it is very large. If I talk about ABPA, you have to treat this patient with corticosteroids because immunity kya hai? It's very high. So we have to use corticosteroids in this patient. We have to suppress the immunity. Whereas if I talk about semi-invasive and invasive, here you have to give antifungals. Okay, which antifungals which we have discussed. Invasive के लिए, especially angio-invasive, the treatment of choice is voriconazole. Very important side effect of this voriconazole is it is basically your photopsia. They will give you some history of visual disturbances that is very commonly seen with voriconazole. If it becomes very resistant even with this, you have to start with IV amphotericin. Okay, so let me know what other topics should I cover. Just mention in the comment section. I have also attached a PDF link of this particular presentation, so if you want to learn, and you can just, you're free to download that, and do subscribe and do like and do share if you feel that this is useful. Thank you so much. I'm Dr. Natisha Arora, and let's meet you in the next video. Thank you.